Okay, so Dr. Selwa, thank you for your patience and for being with us here tonight. Can you just briefly introduce yourself and give us an overview of your experience with the topic, which is epilepsy and sleep?
Nice to be here. I'm pleased you invited me. It's a very important topic near to my heart, really. I have been an epileptologist and epilepsy doctor for about 26 years as a faculty member. I'm a professor of neurology at the University of Michigan. And I've studied sleep. I've had grant money to study sleep and epilepsy, and I've thought a lot about sleep and epilepsy. So the main excitement I have is people managing the sleep problems that come with epilepsy and the epilepsy problems that come with sleep problems. I'm the co-director of the epilepsy program here at Michigan. I also have done an epilepsy fellowship. I'm certified in EEG and epilepsy and clinical neurophysiology. And once upon a time, a really long time ago, when there was no such thing as a sleep fellowship, I spent about 8 months with Mike Aldrich here, who was the person who started our sleep lab at Michigan, learning the same things that the sleep fellows learn now, but a long time ago. So I've had an interest in more than 20 years in both sleep and epilepsy.
Excellent. So before we even talk about the complex relationship between sleep and epilepsy that you alluded to, let's start just by talking about sleep in general, why it's important for everyone, and what we can all do to get better sleep. So first, can you just give us a brief overview of how and why we sleep? So what's going on in the brain and the rest of the body at the various stages of sleep?
As much as we know about it.
Exactly.
I think the why about how we sleep is a very rapidly growing science. We've been able to take many different kinds of pictures of what the brain does in sleep for a long time. It has a very distinctive electrical pattern. In some portions of sleep, the front part of your brain will have brief runs of fast activity, and the rest of your brain will look like it's not working as hard as it does when you're awake. But in other parts of sleep, actually your brain looks just like it does when you're awake. That's during REM sleep, except that your body is paralyzed and maybe there's a little bit more synchronicity. That is, the cells are linked together a little bit more than when you're awake. In other parts of sleep, it looks like the whole brain is working synchronously very slowly, probably because the connections between cells are allowed to play out in a little different way. So that's what it looks like when we sleep. That's a little bit about how and the fact that there are different kinds of sleep. When you just fall asleep, it looks a little bit different than when you're in REM sleep or in the early hours of the morning when you have more slow wave sleep. It's also true that you really don't have charge of the light switch that turns on and off your sleep. Sleep is very much dictated by circadian rhythm, and what your body decides is a good time and place to sleep. So your body makes at least 5 things that help you fall asleep at night and at least 3 or 4 that help you wake up in the morning. If you're not doing a good job making those things, if you've just flown to Europe and have decided this is when you're supposed to sleep, but really your body was wanting to sleep 10 hours ago, it doesn't work very well. So when you have the experience, for instance, of having something like a second wind, that means, gosh, I was really sleepy because my brain was making all the things that help me sleep, but now all those things have sort of worn off and I'm not sleepy anymore. Isn't that great? Or not great, depending on whether you're trying to get to sleep. And I don't know if you've noticed, but if you get up the same time you get up every morning, even if you haven't slept a whole lot, somehow there will be something that gets you going at that time of day. So that's a little bit, all of those things are a little bit about how we sleep. Why was a question that I think everybody was at some level interested in, but people didn't have the tools to investigate until 5 or 10 years ago, really in a rigorous way. So think about this. If we're a whole clan of cave people, it's really not an adaptive advantage to put you to sleep for 8 hours a day, right? If our major problems are predators out there in the world or sudden cold or other dangers that can come when we're not watching, then it's not such a great thing to sleep. We sleep because brain maintenance is absolutely necessary to what we do and how we manipulate the environment and who we are. The bigger an animal's brain is, the more they sleep in general. And the more complicated it is, the more they sleep. And sleep really is a form of brain maintenance. We don't understand everything about exactly how the brain does this, but there's very good evidence now that during REM sleep, you sort of prune emotional memories. Your brain is allowed to sort of run, and the things that induce a lot of emotional changes or stimulate the amygdala and other parts of the brain are trimmed in a way that they don't cause quite as much autonomic overload. If you haven't slept for a long time, you have lots of nightmares because your brain has to catch up on all that pruning. The people with lots of nightmares are often people who are sleep deprived because there's a lot more left over to do for those people. On the other hand, during slow wave sleep, where all the brain is synchronized and firing at the same time and somehow a lot of the neurons are linked, is a time when the brain helps consolidate declarative memory, or sort of just general information about things that your brain has decided are important to keep, and sometimes pruned out general information about things that the brain has decided are not so important. We are an organism that depends on being able to forget things as well as remember things. People who have a photographic memory are people that we all emulate or want to be like, but the truth is that their lives are much more difficult because they can't get rid of things that really are not helping them anymore. So it's really a balance in the brain between remembering what the brain has decided is probably important to remember, somewhat weighted by emotional content and other things, and getting rid of the things that the brain has decided are not so important to remember. Memories are, it turns out, reinforcements between large circuits of neurons that work together. They're not a filing cabinet with each neuron having the picture of your great Aunt Fanny, which I had one of those actually, or someone else in your life. It doesn't work that way. Each memory is sort of a connection between a whole bunch of neurons, and every time you remember that, you strengthen that connection and probably change it a little bit too. You've probably seen some of those things on brain games or other things that tell you that our memory is not immutable for things that we've seen before. Right. I'm sorry, it was probably way more than you wanted me to say, Russ.
No, that's perfect. That's perfect. That gives us a nice introduction. So clearly there's no shortage of information in the media about the importance of eating well and exercising, not smoking, even managing stress to some extent. But sleep just seems to be that health-related behavior that seems to get the least attention relative to its importance. So why is sleep so important? Obviously, you've already mentioned the pruning aspect and how important that is. Are there what other areas of health are impacted by sleep?
I can tell you about lots of other things. I'll try to talk about just the things that have the most clear research. So just very basically, if you don't sleep for about 10 days, you die. So it's clearly very important to lots of different things. In the last year or two, there have been studies that make it clear that people are much better at losing weight if they sleep well. They actually restricted people to the same number of calories, the same diet actually. The people who slept 5 hours were restricted to 5 hours a day for 2 weeks, seemed to lose all muscle and not very much fat, and seemed to gain it back immediately, and then some. People who were allowed to sleep their usual time, or maybe were even encouraged to sleep as much as they wanted to, tended to lose fat and tended to keep it off. So it's clearly important for weight management. It's important for the immune system. Many people have known for a long time that people are prone to infections when they don't sleep enough. I'm not sure I can explain that as well to you. I can tell you that there are researchers in the field of autism who in the last year have gotten a lot of press for saying that sleep can clear even amyloid and some of the things that we worry about building up when people develop chronic dementia. I don't think anyone can cure dementia by sleeping, but people believe that it may be problematic to our brains, that many of us are chronically sleep deprived, and that may be part of the risk factor for developing this sort of trouble. It's very clear that sleep deprivation has a very measurable impact on mood, even the next day. If you get someone between 3 and 5 and administer a test sort of designed to look at irritability or mistake-making, it's always worse when people are sleep deprived, no matter what we think about how well we tolerate that. Blood pressure tends to go up. It's clear that people make many more mistakes. There have been lots of people who've talked about the fact that the people in Chernobyl were sleep deprived, that various people who were really involved in some of the major frightening things in history where just a momentary glitch caused a problem were sleep deprived. So there are lots of issues in terms of changes in the way we're able to process things when we're sleep deprived.
Right. Very good. despite this overwhelming evidence regarding the importance of sleep, many people, as you know, do not get enough high-quality sleep. And maybe it's just that sleep isn't a priority for that person. Maybe the person just has bad sleep habits, or maybe, as is the case with epilepsy, there may be medical factors involved. In any case, what are just some of the general guidelines regarding sleep, particularly for different age groups? And then how can people assess whether they're getting enough sleep and whether their sleep is sufficient?
Yeah. So the average amount that people on the planet, not just in America, need to keep themselves from making more mistakes, being more irritable, all those things that measure sleep deprivation on objective tests, is 8 hours and 15 minutes. That there's sort of a bell curve around that. There are some people who do okay on a little over 7 hours, or some people who really need 9.5 hours. But there's nobody who does well on less than about 7 hours and 15 minutes, and there aren't too many people who need more than 10 hours in a day. So in general, you have to figure out how much sleep your body really needs. If you feel like you sleep 2 or 3 hours more on the weekends than during the week, it's fairly clear that you're not getting enough sleep during the week. In general, the most important things are going to sleep at the same time, getting up at the same time, not doing other things in bed besides sleeping, and trying to have some assessment of when you've really had enough sleep and feel refreshed and when you haven't. I feel very strongly about keeping the same sleep hours because it really makes people function better and take the best advantage of what their brain and body are trying to do.
Okay. And what are some of the key signs that you're not getting enough sleep? Obviously, feeling drowsy. Are there other signs that people should be aware of? Because some people might be saying, "Well, I'm getting my 8 hours of sleep, but I still feel groggy."
Right. If you always have a much nicer personality on the weekend when you slept in a few hours, right? A few of us can say that. Maybe it's because there's nobody else around. And just, be honest with yourself about if your spouse tells you fall asleep on the couch reading the paper, you probably do. And if you feel like you really, can't possibly exercise because you're just way too exhausted and fatigued, a little bit of extra sleep might actually help that. So think a little bit about how emotionally and physically just drained you are at the end of a day, and try to figure out if adding a little bit of sleep will help. Figure out whether you fall asleep doing things that are really boring, or if the TV show isn't good enough, then you'll fall asleep. Normal people don't fall asleep in 5 or 10 minutes in front of the TV if it's not a good show. For most people who have had enough sleep, it takes over 20, 25 minutes to fall asleep even if they try hard during the day. So that'll help you a little bit. I think that's what you're asking, Ross, about.
Exactly. Okay. So, again, you've mentioned this a little bit, but what are some of the most important steps that all people can do to improve their sleep?
So again,
regular schedule and
within a half an hour, going to bed within a half an hour of the same time, and getting up within a half an hour of the same time every day. And if it's painful, because if you work the night shift, that means doing that on the weekends too. It's very hard for your brain to go back and forth between two completely different schedules and get what it needs out of your sleep. So keeping the same sleep regimen as much as you can every day is handy. Not doing things in bed other than sleeping and a few other things some people like to do with the lights off, but really watching TV, doing paperwork, all kinds of other things that might be comforting and happy to do in bed are not a good idea. Your brain depends on signals about when it's supposed to be going to sleep, and if you really mix those up for it, it won't know if the bed is really meant for reading the magazines that came today or whether it's really meant for sleep. A cool room is also a good thing. Having your room not be too hot actually is something. There's some engineers working on that. Those people you see on TV with their cold pillows are getting that information from basic scientists who wonder if cool helps facilitate sleep. But that's still something we haven't figured out entirely. But clearly dark, not sound, not doing other things in bed. If you really feel agitated about something, get up, sit somewhere else, read for a while, do something else for a little while that's not too awfully exciting, and then try to sleep again. Turn the clock around. Don't be staring at the clock every 5 or 10 minutes to see if you've fallen asleep yet and how much less sleep you're going to get now than you thought you would. That's not very helpful in terms of improving sleep. And sometimes I tell patients if they feel like they have lots of racing thoughts when they go to bed, it means that maybe they should find a time during the day somewhere to put those racing thoughts down on paper, look at them more objectively than you do as you're falling asleep, and do something with them.
Right. Okay. So now that we've talked about sleep in general, let's talk about how sleep and epilepsy are related, both how sleep affects epilepsy and how epilepsy can affect sleep. So for starters, many types of epilepsy feature seizures that are connected in some way to sleep. So can you talk a little bit about why seizures may be more likely to occur at different points in the sleep cycle, and review how some of the specific epilepsy syndromes might be connected to sleep?
There's some we understand pretty well. There are for many people, that relationship with sleep is individual, and not for everyone who has the same kind of epilepsy. But if you think about epilepsy as an electrical disturbance in the brain, sort of a glitch in the software, when the brain is abnormally synchronized at night, there opportunities are presented for cells that don't have access to the whole brain to do things that affect the whole brain. And sometimes there are also opportunities for different kinds of the brain being suppressed. The motor part of your brain is suppressed during some parts of sleep and in other parts not. That will affect whether the electrical abnormalities that are causing trouble for you and making seizures can happen at different times of sleep. So the most well-recognized syndromes are benign epilepsy with central temporal spikes, or Rolandic epilepsy in teenagers, which is something we love to talk about because it's usually not horribly disabling, and it almost always goes away by the time you're 20. Generally happens shortly after falling asleep. It's something that is a sleep initiation epilepsy. We see evidence of it much more often when people are having an EEG shortly after they fall asleep than we do when they're awake. That's one of the reasons everyone who has an EEG, we sort of try to convince you to sleep so that we'll see a little bit of what the brain does while it's asleep as well as awake. There's another kind of epilepsy called juvenile myoclonic epilepsy, or generalized seizures on awakening, which are two different things that happen really only after your brain sort of tries to reset and get started again and desynchronize. Those are things that happen much more commonly early in the morning than later on in the day, not always dependably. Some kinds of frontal lobe epilepsy seem to happen more often in non-REM sleep than they do in wakefulness. And there are lots of patients, individual patients, who don't have well-recognized sleep-related syndromes who have seizures primarily in sleep. And there are individual patients who will never have seizures in sleep and seem to have seizures always only when they're awake. Just depends on what the influences on their particular seizure generators are in the brain from the different stages that your brain goes through in sleep. Does that help a little?
Yeah, absolutely. So we know overall that for many people with epilepsy, sleep deprivation is a common trigger for seizures. So when people are keeping a seizure diary or a journal to track their seizures and look for potential patterns or triggers, should they only make a note of poor sleep that occurred the night before the seizures, or is it possible that poor sleep from a few nights ago, or maybe poor sleep for the whole week could have triggered the seizure? I guess what I'm getting at is, can sleep deprivation have like a delayed or cumulative effect, or is it likely to be immediate, like the day after you have a bad night's sleep?
Both, I think. So I live in Ann Arbor, and I take care of patients here, and I see lots of students who have decided they need to pull an all-nighter, right? Those kids are at much higher risk for having seizures in that setting. Something about not doing the work of homeostasis, not taking care of sort of cleaning up the brain that happens during sleep, makes it more likely for electricity to get a little confused. I think people understand that generally. What sometimes people lose track of is, I had a child 6 months ago, I've had a lot more seizures since the baby was born, maybe it's hormonal, or maybe it's because you're generally much more sleep deprived. So keep track of those episodes in your life where you're pushing yourself much harder, you're much more stressed. Someone like my daughter goes off to college and calls you only at 12:30 in the morning. There are lots of reasons why you might be having overall a little bit less sleep. That generally doesn't affect people right away, but it can certainly increase people's seizure frequency over the longer term, just like stress does.
Mm-hmm. Okay, makes sense. So for a number of reasons, people with epilepsy are more likely to have sleep problems. Can you review what the research has shown in terms of how having epilepsy affects sleep? We've kind of talked a little bit about how sleep affects epilepsy, but...
So, exactly how these things happen, causation and correlation are a little bit hard to separate out sometimes, but people with epilepsy are much more likely to have both obstructive sleep apnea and central apnea. That means times when your throat further down than what you can see in the back of your throat, but closes down while you're breathing and has to be opened up again by waking you up. That's obstructive sleep apnea. Or central sleep apnea, when your brain just doesn't pay as much attention to the usual cues about when it needs to breathe more and when it needs to breathe less. Those things happen more often in patients with epilepsy. 30% of patients with seizures have obstructive sleep apnea. They also have more periodic leg movements of sleep, restless legs, and in general, having epilepsy sometimes means that your brain is less good at generating sleep. Sometimes means it's more good at generating sleep. The head injuries and other things that can cause changes in your brain's ability to put itself in different stages also have an influence on the possibility of seizures to some extent.
Now, we know that anti-seizure medication can affect sleep. Is it sometimes hard to tell what's responsible for having difficulty either falling asleep or having good quality sleep or staying asleep? In terms of whether it's anti-seizure medication side effects or whether it's the epilepsy itself?
I don't think very often about epilepsy causing more sleepiness unless people are having numerous seizures a day.
Okay.
Our medicines can do that, or the sleep disorders associated with epilepsy can do that. So what I want to get across is that it's important to think about the medicines that are associated with worse sleepiness during the day are phenobarbital, sometimes Depakote. Very high-dose levetiracetam can cause people to be more sleepy. So if you have a patient with a seizure disorder who's more sleepy, first of all, you find out if they're getting enough sleep, right? If that baby is not crying in the middle of the night. Then you find out whether they're on more medicine than their tolerates. You can try to figure out whether things were different at different points on the medicine. But you also have to look into whether they have one of these associated sleep disorders. If you have obstructive sleep apnea, you could be on 6 different medicines and still remain sleepy, but really the cause is something that's associated but perhaps not caused by the epilepsy, the obstructive sleep apnea. The medicines, there are medicines that can actually make your sleep better sleep latency, better efficiency, gabapentin, tiagabin, pregabalin, clobazam, carbamazepine, all of those things at some point or another people have thought for reasonable scientific reasons might actually make the amount of restorative sleep look a little bit better. There aren't really many other medicines. Most of the rest of our medicines, topiramate, zonisamide, lots of other things, don't seem to change sleep in one direction or another.
Okay. Because I know people might be trying to frantically write down as you mentioned this. Can you review the ones that are likely to or that can interfere with sleep, and then the ones that are possibly
I don't know that the only medicine that can cause insomnia that we see on any regular basis is lamotrigine, but it actually doesn't change sleep architecture. It doesn't make people more sleepy during the day. Generally is actually, if anything, neutral or good for sleep. But medicines that can make you feel more sleepy during the day, phenobarbital, I think everybody has an idea that could make you feel more sleepy during the day. Depakote also is associated with more daytime sleepiness. It's not entirely clear how. High-dose levetiracetam in some studies reduces the amount of slow-wave sleep that people have and can leave people a little bit sleepier, more than 3,500 usually. I wouldn't use any of our medicines as things that really help sleep or really prevent sleep. I don't think seizure medicines, it is not our usual experience that those have a huge impact on those things once people are used to the medicines and we're clear about what dose they need or can tolerate.
Okay. So as far as sleep apnea and some of the other sleep disorders associated with epilepsy, what are some of the treatments available for that have been shown to be effective?
CPAP for sleep apnea, the kind of treatment that supports your breathing, just kind of keeps your airway open at night, helps both with obstructive sleep apnea and to some extent for many patients with central sleep apnea. It is quite useful for people. The only caveat is that if you have a VNS and have sleep apnea, you might want to actually think about, your doctor might want to actually think about making sure that you tape the magnet to it at night. So if you have a VNS and you have bad sleepiness, a sleep study can be especially helpful because they can try to figure out whether the VNS is making your sleep apnea worse at night. VNS doesn't seem to cause sleep apnea, but if people have sleep apnea, sometimes it seems like it makes it a little bit worse, if that helps.
Right.
And there's lots of treatment for both restless legs and sleep apnea. Restless legs is medicines, and sleep apnea is usually a mask that you wear just over your mouth and nose or just in your nose that helps just increase air pressure in your throat and keep your throat open at night.
Right. Okay. So given the fact that anti-seizure medications may affect sleep, it sounds like it's not common that they do, but when is it appropriate to consider changes to your medication regimen in order to get better sleep?
I think that's something everybody should talk about with their doctors. The only thing I want to make sure folks understand is you have to talk about both, whether it's too much medicine and whether anything else could be making you sleepy. I've seen lots of folks who have been through trials of 4 or 5 medicines saying, but I'm just as sleepy on all of them. Then you have to think about whether anything else is making you sleepy. So both of those things need to be considered and discussed. And you need to start keeping a diary to keep yourself honest about how much sleep you're getting and how much sleep you really might need. It may be that you need 8.5 or 9 hours of sleep and you only used to need 8, and that can make a big difference in how you function during the day. Mm-hmm. And a VNS actually, in general, is good for increasing slow-wave sleep. Ketogenic diets are good for increasing slow-wave sleep. So most of our treatments can have a beneficial effect on how effective sleep is at clearing things that are not useful in your brain.
Okay. And as far as the VNS increasing slow wave sleep, the only potential downside is the increased risk of sleep apnea or aggravating sleep apnea?
Right,
okay.
Right. I haven't met anyone yet who didn't have any sleep apnea without their VNS and did with VNS on, but if you have a VNS, the more slow-wave sleep will make the sleep apnea worse.
Okay. So what are some specific recommendations for people with epilepsy who aren't getting sufficient sleep? We mentioned some of the general recommendations for anyone who's sleep-deprived, but is there anything specific that you would recommend for people with epilepsy?
Just finding out how much sleep works for you and makes you feel good. Take some period of time, maybe you're on vacation or some other time, and figure out how much you really need when you can sleep as much as you need to, and try to see if you can stick to that for a little, just for your own self, for a week or two, see how much difference that makes in your life. I actually, under this question, many people like to talk about what sleep aids they should use to fall asleep. I'll tell you, I'm not thinking that's a wonderful thing for patients with epilepsy in general. Most medicines, including Ambien and most of the other medicines that are prescribed, are a form of benzodiazepine, which is like Valium or Ativan, if you've ever had those medicines administered. They tend to make the parts of sleep that do things for your brain a little less good, and they do tend to make you fall asleep faster. Alcohol has the same effect, makes people drowsy, but makes the useful parts of sleep, REM sleep and the deeper slow-wave sleep, much less effective, and actually the nights contain much less of them. In an ordinary night, you have 5% drowsiness, about half of it is stage 2 sleep, about 15% is deep slow-wave sleep, and about 20 or 25% is rapid eye movement sleep. So changing those parameters and really suppressing the rapid eye movement sleep or the slow-wave sleep are not things that are really good for your wakefulness the next day. And in general, I'm not crazy about most of the benzodiazepines for that reason, and also for the reason that if you took them for 2 or 3 weeks and stopped, you might be more likely to have a seizure for the couple of days after you stop. Melatonin is a reasonable thing for folks with epilepsy to make. It's actually to take. It's actually one of those things that your brain makes to help you fall asleep. They started out when they figured out that was one of those agents, using it in patients who were blind, because melatonin is secreted in the brain when it gets dark outside, and specifically eventually is tied to your sleep cycle in a very specific way if you keep a regular sleep schedule. But patients who are blind really don't have a lot of triggers to make it, even from when they're very young. So they get injections of melatonin, which are very helpful to help them regulate their sleep cycle. There's a lot of controversy about Benadryl and Tylenol PM and other things. I think for the most part those aren't harmful, but I have some patients who think that even antihistamines make it a little bit more likely for them to have seizures if they have frequent seizures.
So that's something you can kind of decide on an individual basis and talk to your doctor about. Okay.
Yep.
So obviously a lot of people don't get ideal sleep, but under what circumstances should people consider seeing a sleep specialist or having a sleep study done? And is this typically covered by insurance if you do decide to
sleep studies are covered by almost every kind of insurance. There are some now who are beginning to ask that people have at-home studies, which are cheaper, a little bit harder to look at, and sometimes less conclusive, sometimes not. I think if you're consistently sleepy no matter what medicine you're on or what dose of medicine you're on, and you're getting enough sleep, it's quite clear to you that more sleep doesn't seem to change that equation, then you need to talk to a sleep specialist or talk to your primary care doctor or your neurologist. Many people are delighted to order you a sleep study who are not necessarily a sleep specialist. So you can do any of those things.
Okay. And what, just for people who aren't familiar, what are some of the signs of sleep apnea that people should be aware of?
Mm-hmm. So first of all, you have to listen to anyone in the room with you. If someone is telling you that you really snore, you don't know a thing about it, and they do, so you have to pay attention to that. If someone in the room with you has told you that there are periods of time when you hold your breath at night, the correlation between that and sleep apnea is more than 80%. If you're falling asleep doing boring things fairly regularly a few times a week, you have to think about whether sleep apnea might be a problem. If you wake up with a very dry mouth, you've probably been breathing through your mouth and possibly snoring. If you get up a lot to urinate in the middle of the night and you don't think it's related to normal issues of aging, that can sometimes be a symptom of sleep apnea as well.
Right. And are there different types of snoring? Is there a particular type of snoring that's less likely to be sleep apnea, or is any snoring a fairly good indicator of sleep apnea?
I wish. So the people who respond tremendously well to those nose guards, I don't know who they are because I haven't met very many, but probably really do have a nasal septum problem and don't have sleep apnea as a source of their snoring, but they usually don't snore very loud, and it's usually not a significant issue. Most people who snore are snoring because something much lower down in their throat has closed off, not their nose.
Okay. So we've talked again about some of the impacts of epilepsy on sleep and sleep on epilepsy. What are some of the risks associated with nocturnal seizures? Some people, again, we talked about certain types of epilepsy that are associated with nocturnal seizures. What are some of the risks associated with those, and is there anything that can be done to reduce those risks?
It's an interesting way to put it. I think it's conceivable that there are patients, certainly patients with primarily nocturnal seizures, should do things like consider what sort of pillows they're using. Usually smaller, harder pillows are better than huge soft pillows in case you turned over on your stomach and had problems breathing with that pillow or slept alone.
Are there? I know a lot of places market anti-suffocation pillows. Is there any evidence that those work, or that
no? But it wouldn't be a horrible thing to do if you slept alone and had nocturnal seizures. I think that would be a reasonable thing to do.
Okay.
I don't know what to tell you about using movement devices or heart and breathing monitors. I think sometimes they're very useful in patients who have very severe seizures and have them generally at night, but I've also seen families really get almost disabled by how carefully they listen to monitors at night, and that I don't believe that's necessary for most people.
Okay. So what because we do have, I can say we have a lot of people who contact us asking about those types of things and those devices that can alert them to a seizure at night. And are there particular risk factors or types of epilepsy where that might be a better idea than others?
There are some babies who have fairly severe problems, babies with West syndrome, and very small children who have a greater likelihood of obstructing their airway anyway, in whom those are useful. For adults who have their seizures in a fairly mixed way during the day and night and don't tend to cluster in terms of having a bunch of seizures in a row, I'm not sure it's always necessary. For people who usually have 3 or 4 seizures in a row once they have one, I think it's a useful thing to have a monitor.
Okay. As far as tracking seizures as a way, again, to judge your seizure control and report back to your neurologist about that, how important is it to track seizures that occurred during sleep? Again, you're trying to balance the idea of getting all of or tracking all of your seizures, but then at the same time you don't want to have your family members staying up all night trying to watch for any sign of a possible seizure. That's
actually not a clinical question I hear too often. We'll have to hear from folks whether that's something that people really worry about. So if people are living alone, they'll tell us if they wake up very confused or having wet the bed or bitten their tongue or feeling like they're sore like they usually are after a seizure. And usually people know about those more major things. Obviously, if something very minor happens in the middle of the night and you don't know about it, you can't track it. So I would track it just the same way that people track what they know about. I don't think it's necessary for someone to sleep with a patient to tell me exactly how many seizures they have at night if they have them in a mixed way during the day and the night. But it's important to tell us about whatever happens. We can help you make a judgment about whether that really strange dream seems like something that could likely have been a seizure or not. But sometimes it's less significant if people only have simple partial seizures during the day, for instance, and no one else who was in the room with them noticed that this event happened. We might talk a little bit about how much it resembles their aura or how much it resembles other things. I don't think that it's necessary to try to sort out 100% of the time what those things are, but I do think it's important to pay attention if you suddenly wet the bed and that only happened when you have seizures, right? It's important to know if you've bitten your tongue that really is pretty likely to be a seizure unless there's something very strange about your dental work.
Okay. Speaking of nocturnal seizures, are there times or circumstances under which people who have exclusively nocturnal seizures should be allowed to drive? I know that's a difficult question, but
it's a really hard question.
Yeah.
So what we are obligated to do if someone asks us to talk to the Secretary of State about this is to write that they have only nocturnal seizures. I think it depends on what county, what particular person in the Secretary of State's office even reads those things, because the vast majority of the time, no matter what I write on those forms, if you've had a seizure of any kind now within 6 months, the Secretary of State is not going to say that you can drive. There was a time when we got exceptions for people who had only nocturnal seizures, but I'll tell you, in my 26 years, there's been at least once or twice I was sorry about that. So I don't, unfortunately, I wish I could tell you that if you've had 95% nocturnal seizures that we can, even if you've had 100% nocturnal seizures, I can't guarantee you the next 2 years are going to be the same way. Epilepsy doesn't function that predictably for many people.
Sure, and there probably just haven't been enough research studies on your likelihood of having an accident or that type of thing.
Right. The tendency in the Secretary of State now, I can tell you, is that they don't care particularly much about what we say about whether we were changing medicines or whether the seizures only happen at night. They fairly strictly follow the rule about 6 months.
Yeah. So that's probably true for people who have only simple partial seizures as well.
Oh, I wish I knew. So I don't know what to tell you about that. It depends, again, on the circumstance. If you've had, I would tell a patient not to drive if a patient had no simple partial seizures after surgery for 3 years, but now is having them once every 2 weeks, because I don't know exactly what's going to happen. Right. But I'm not, the Secretary of State rule does not say only people who lose consciousness. It says has any kind of seizure or loses consciousness. So it also depends on the way that's interpreted to some degree. The most important thing for me is that in this state we don't have a reporting responsibility, so I can talk through with my patients what we feel about their individual level of risk and what that means without having to write the Secretary of State a card and saying this patient had a simple partial seizure, I guess I have to tell you about it.
Right.
So hopefully people can have very honest relationships with their doctors about exactly what's happening and what level of risk that presents.
Right.
But certainly any episode where you sort of lost track of what you're doing for a very short time has to be taken very seriously.
Okay. One thing I wanted to ask about is there are now some sleep apps for smartphones where they're basically, an iPhone has an accelerometer which can measure movement and that type of thing. So there are apps where you can it can measure the amount of movement during the night, and is that a reasonable indicator of sleep quality? The amount you move in a night, and are such apps even worth trying? Obviously it's not going to diagnose a sleep disorder or anything, but
you're trying to accomplish. So people with restless legs, for instance, will have lots of evidence of movement, but still actually be asleep. They might need treatment for that. Okay. People who have sleep apnea will have a little bit more movement than people who don't, but people over a certain age will have more arousals and movement anyway, and there wouldn't probably be very much we're going to do about that sort of level of sleep efficiency in older individuals. Okay. I don't think apps are quite ready for that yet. I would love to see an app that told us for sure if someone moved in the same way that they do when they're having a seizure. And there are people working on those, honestly. Oh, sure. There's someone in my department working on that. But we don't have those yet. So I think those are not quite as helpful as they might be someday when we understand them better.
Right. Okay. All right. Well, we've covered most of the information I had down. I guess we can open it up for questions now. Hopefully people take advantage of this time to ask questions. Who would like to go
first? Hi, Russ. This is Dawn Esparza. I have a question about my son. He has epilepsy. He is 5 years old. He was diagnosed when he was just 3 in 2012. He's only had 5 seizures. He didn't have a single one in 2013. So we're looking really, really good. He's taking Trileptal. He's taking Keppra. He's had no side effects. I've been strict on his bedtime, ensuring that he's getting enough sleep. I think I've put mine at risk, as you said, staying up with the baby monitor on my chest, but I'm okay. The other day, I was with my son as he was falling asleep. I do this. I can't pull myself away. I need to make sure he falls asleep because his seizures have happened as he's falling asleep or if he wakes up super early. So that's my danger time. That's when I keep a lookout. So I stay with him to make sure he drifts off safely. Well, we were chit-chatting. He was quiet. And then it seemed like within just a few minutes, he was whining. And then he was pointing at his eye. And then he was limp. And in 20 seconds, he woke up and said, "Mom, I had a bad dream." And his heart was pounding. Mm-hmm. And I was panicking. I thought, how could you have a bad dream? You just fell asleep. Mm-hmm. And I'm thinking, oh, no, it was just a seizure. This was nothing like the 5 that he's had. Absolutely nothing like it. Is it quite possible that he had a dream so quick upon falling asleep, a nightmare, that he woke up?
It happens a lot when kids are sleep deprived. It happens a lot when, if you've taken your kids traveling and they fall asleep somewhere. So the limp part makes me think it's possible it's a dream. There's also something called night terrors that is not terribly uncommon at your son's age, although usually that doesn't happen for a good 45 minutes after they fall asleep.
Okay.
I think it's more likely that it represents one of those sorts of things than a seizure.
Okay. I had called our neurologist to pass along the information. She never called back, so I figured she didn't think it was a big deal. But, because we are so focused on being 2 years seizure-free.
Sure.
You know, and we've already made it. It was a year in November seizure-free. So if we can make it to November this year.
Good for you.
We're working on it. But then
your son doesn't talk in his sleep or walk in his sleep, huh?
No. And, you know, I watch him. I listen for him. So I know exactly when he's about to toss and turn. You know, he's usually asleep at 8. He'll roll over at 10 o'clock, you know, a couple times. So I've been like a hawk watching him sleep, listening to him sleep. And I guess there's really no way of knowing.
I think my best advice to you is to turn the baby monitor down by about 10% every week.
Oh, that's a lot to ask.
Think about it.
That's a lot to ask.
Think about it. Because in the long term, honestly, he needs you to be very well rested and not anxious about him. And he needs
not
you
grouchy.
Sorry?
And not grouchy and ask him 100 questions. Are you okay, honey? Are you okay? Are you okay?
It's not so bad when they're 5, but if that's really how he grows up, he will be different as well, you know?
Right.
So sometimes you just kind of have to let things. None of us know what's going to happen anytime, and there's not a lot you could do to prevent something from happening. So you need to get sleep. And it's going to have to be gradual, I bet, but just a little bit at a time. Turn the baby monitor down. I'm not telling you throw it out. Yes, your husband's right. My husband told me that too, and I didn't believe it either, but he was right. It's really much better for everybody.
And another quick thing, I know you've got a million other people that want to talk to you. It's sometimes difficult to determine if your 5-year-old son really doesn't want to get up and go to school because he doesn't feel like it, or if
is a 5-year-old.
Or if he's confused or tired. Maybe something did happen last night and I didn't catch it. You know, sometimes it's hard to tell.
Don't do that to yourself.
If
something happens at this time out after you've known he's had a seizure, if something happens, you'll know about it. The day will be very different. And the rest of the time, just don't even do it yourself. There's no reason to.
Okay, because I need sleep.
You need sleep. Everybody needs to be calmer. He needs not to be treated like he's made of glass, because I've seen what happens in the long term when that happens. It gets very confusing for him and for everybody else. That in the long term, he will be slightly less healthy if you are really sincerely worried about him all the time. So you have to figure out how to dial it down, in my opinion, just a little bit at a time.
Fabulous. Linda, thank you so much for your time, and I've enjoyed listening to you. Russ, thanks for facilitating. This has been incredible. I hope to call again on another conference. Thank you.
Thank you. Good luck.
Other questions?
Yes, doctor. Yeah,
I have a question.
This is Karen.
Go ahead, Karen.
Go ahead.
Okay.
Al, you can go next.
Hi, doctor. Like I said, this is Karen from the support group. I have restless legs, and I've been taking stuff like over the counter. Is there something else I could take
for restless legs?
Yeah.
What do you take over the counter for restless legs?
Restless legs.
I don't know what's in that.
I don't either.
Okay.
But
the treatments we have
legs.
The treatments we have that work, none of them are over the counter except for some people who are iron deficient and need to take iron over the counter. Okay. So if you believe you have that, I think you should talk to your doctor about having a sleep study and use the prescription medicine that usually just gets rid of it. I know people can be reluctant about prescription medicine, but none of those are scary, dangerous things for that disorder.
The reason why I got it is because I was carrying my last child, who's almost 25. She was on my back, kicking my spine a lot. And after I gave birth, 2 days, that started.
So what you experience is that you need to move your legs and make them feel better various times as you're going to sleep, or you
going to sleep or driving. Or sitting here doing my artwork, any of this stuff.
You know, it's very smart to talk to your doctor about it. There are a number of other things that could cause restless legs to start that they might want to think about. I can't really go through all of that with you here, but mostly non-dangerous things, but things that only your doctor, who knows everything you take and about your medical history, would be able to talk to you about. So I would not depend on anything over the counter, because honestly, I don't know of anything over the counter that works. So I would encourage you to talk to your doctor about your symptoms, tell him that you believe you may have restless legs, and they will do the right things to make sure that there aren't any deficiencies you have or any problems you have that could be causing that, and give you the right kind of treatment.
Okay, because they did see it when I went through phase 1 before the brain surgery, and back then they had no name for it.
Okay, I don't know how long ago that was.
15 years.
Yeah, we had a name for it then. We did.
Ah.
I don't know if you probably didn't have a sleep study. You just had the overnight EEG, and they don't analyze it the same way that the sleep studies are analyzed.
Right.
So that existed 15 years ago. It existed 25 years ago when I started. So, and just talk to your doctor now about it. And if he doesn't know, I'm pretty sure they'll know what restless legs are. But even if they don't know, tell him that you know about that and you are wondering about that, and that it's fairly straightforward. But he needs to talk through your medicines with you and other health history to make sure there isn't something else they could do.
Okay.
I have a question.
Thank you.
Go ahead, Al.
I have a question.
Go ahead.
Okay?
Sure.
But before I wanted to tell you something that happened to me. I usually go to bed at normal time, like you said, and I don't have a problem with that. But one night I had a dream that I was having a seizure, a tremendous seizure, and I was with my wife and other people, and it was so unbelievable, really a tough one. And it was going on, and all of a sudden I woke up, and I almost had a seizure from having that dream, but it was really terrible. I don't know, it was the first time that ever happened to me.
Yeah.
But it was really, really bad. I don't know what caused it.
I don't know what caused it either. Mostly nightmares are nightmares, and having a seizure is a pretty bad thing to happen.
It never happened to me before, and I don't know what I did.
I mean, people occasionally dream about dying. They occasionally dream about any of the things that are really scary and bad that happen to them. I have had patients where they'll think it starts sort of as a dream, but their partner will tell me that no, it went on to look like her usual seizure. But the vast majority of the time, those are just dreams.
Okay, well, I'm at the age now where I have to get up during the night, of course. Yeah. And when I get up and I get back to bed, and I had this. I started getting depressed and thinking about things that I didn't do and things I should do and all that. I get depressed about it, and then I start having neura.
You know what you should do? I think the problem with those kinds of things is somehow as you're half asleep, they turn into big fat monsters. Yeah. If you actually think about them during the day, they often don't occur to you the same way, and they don't bother you the same way. So I would take some of those things that occur to you in the middle of the night and really write them down. Write about them. Write what you can and can't do about them, what you do have control over and what you don't. And then a lot of times they'll stop bothering you so much in the middle of the night.
Yeah, because, well, how about depression?
Depression is a very common thing in patients with seizures, and depression will sometimes make it harder for you to fall asleep. So there are medicines that you can take for depression that might help with sleep. For a lot of our patients, that's helpful, not for everybody. And I'm not, I wish I had an easy answer for going back to sleep for everybody, but depression is most definitely one of the things.
How about Xanax?
Xanax is not my favorite idea for the reasons that I said before. It's like Valium, and if your body gets dependent on that, whenever you don't have it, you'll be more likely to have a seizure, and overall it just makes your quality of the sleep you do get worse.
Well,
that's a good point. You mentioned, Dr. Selwa, about depression and epilepsy, and that depression can definitely affect sleep, either make you sleep more or make you sleep less. And it's important because so many people with epilepsy have depression to get evaluated for that if you haven't already. If you suspect that you might have depression, like you said, there are medications for depression that can be safely taken with epilepsy, and then there's also counseling, psychotherapy that can help you deal with some of those issues that might be keeping you up at night. So.
Well, because I was always so active, and now because of epilepsy, I'm not active. Yeah. And I feel I could still do it, but I can't. Right. So now I'm depressed.
So those are types of things that maybe talking with a counselor or another mental health professional would be helpful to go through. So, other questions?
Yes, I have some concerns. This is Michelle. I seem like when I do have sleep apnea, I do use my CPAP every time I lay down. Seems like the nights that I sleep, I feel I sleep well, I have more bad dreams, and I actually wake up with a horrible migraine, whereas the nights that I don't feel like I sleep very well, I wake up feeling better in the morning. Is that part of the epilepsy, or is that...
Most of the time when people catch up in terms of how much sleep they get, they have more nightmares, but that's actually a useful kind of sleep usually. Do you get up at the same time every day too?
Yeah, I'm pretty close, yeah. I mean, I don't have any set schedule, but I pretty much am up. I pretty much go to bed at the same time and get up at the same time.
Right. I mean, a lot of times that feeling of grogginess when you get up in the morning happens either if you're getting up at an hour that's way before you're used to or an hour that's way after you're used to. So lots of people will tell me they feel much more groggy on the weekends when they get more sleep, but it's mostly just because your brain gets a little mixed up about all of those waking up signals.
Yeah, okay.
I would
dreams be horrible.
I understand. Usually the more sleep deprived you are, the more bad dreams you have, so it usually means you need more sleep.
Okay. All right, thank you.
Someone else had a question?
I have a question. Actually, I have 3 related questions.
Okay.
My name is Amy, and I just want to say, I want to begin by saying thank you so much for coordinating this session. It's been really, really helpful, and I'm actually listening on behalf of my 7-year-old son who developed epilepsy. He had his first seizure on Christmas Day in 2012, and since then it's been a real learning journey for me. But I found some of what you said in the very beginning actually helpful for myself as well. So my son initially, at Mott, they diagnosed him with epilepsy and began him on Keppra, but it didn't seem to help. He was seizing at night, and we kept increasing the Keppra, and then eventually they asked us to try the ketogenic diet, and that didn't help either. And then he began taking Onfi, and that didn't help. About the beginning of August, they diagnosed him with something called CSWS, which is continuous spike and waves during slow sleep.
Yeah.
And then they were really not sure how to proceed, and I began reading about it and got very, very worried. And I started reading some additional specialized and found a researcher at Boston Children's Hospital contacted, and we went and saw him in October. And then that researcher and the doctors whom we were working with at Mott really graciously agreed to work together and started him on a treatment with steroids, which his last two EEGs have come back clean, completely clean, with no CSWS pattern. So hopefully his third will as well, and we can begin to taper him on the steroids. But he's been on steroids since November. So that's the background on this. So I have questions. One is that I understood that most people with CSWS often outgrow this at adolescence. But as I've been reading further, I've noticed that there are documented adults CSWS pattern. So I wanted to ask how common that is and if the effects or consequences are as troubling as they are in children. That's my first question. My second is about...
Take these one at a time.
Sure.
That'd be easier. So, one, it's a very uncommon disorder to begin with. As you know already, I have a feeling.
Yes.
I guess I'm not sure if I understand your question exactly. Are you saying so if you don't have continuous slow waves in sleep anymore, if he has gotten rid of those on steroids, then I don't think we need to talk about adults with continuous slow waves of sleep. Right?
Well, my understanding is relapse is very, very common. So
it can happen.
Yes.
But I don't know what question you're asking me. Are you asking me, is he going to relapse? What is his outcome? Is that what you're asking me?
No, I'm asking because they had, so when I was initially reading, my understanding was if you can kind of help the child get to adolescence, they often outgrow it. But then as I started to read further and saw that there were documented cases of this in adults, I was wondering if you knew how frequently they were, you all are finding
It's
adults.
very rare in adults. Almost everyone who has it as an adult has had it all their lives, as far as we can tell.
Okay. Thank you. So my second question has to do with an unexpected death during sleep with epilepsy, and I'm wondering if you could talk to us a little bit about that, and also if there's any correlation between that and a CSWS pattern.
Yeah. It is a risk for everyone with epilepsy, not necessarily in sleep. I don't think it has a lot to do with sleep, to be honest. I think it's a risk in general for one out of anywhere from 3,000 to 100,000. The jury is still out about that. Patients with epilepsy. It's not a common thing. It's generally there primarily with people who have many more seizures than others. Usually people with continuous, your doctor can answer this question better than I can, honestly, because it depends about a lot of things about your brain. Continuous slow waves of sleep does impart some increased risk of SUDEP, but not in a way that you can prepare for or should be anxious about, in my opinion. It's something, again, if he's not even having that pattern at this point, it's not something that should be part of your daily consciousness. But I would have to know some things about him a little bit better than I do now, even, to give you the best advice about that. And I think your doctor is the best person to talk to you about what those risks really are for him.
Okay. So can I ask one more question?
Yes.
And that was, I was reading about some new therapies that were presented that had to do with the generation of...
I'm sorry, I'm missing part of what you're saying.
Okay, I was wondering, I've been reading about, a friend forwarded this to me about Sage Therapeutics had presented something on the generation of synthetic neuroactive steroids with positive modulatory activity at the GABA-A synaptic and extrasynaptic receptors. And I was wondering if this, like, I didn't really know what this meant. I asked my one doctor that I was working with who's a fellow, and I said, is this going to, does this have something to do with certain patients who...
I don't think it means anything just yet. I think they're trying to develop agents like that for use in epilepsy. And I don't know that they're any different for you at this point than the steroids that he's already gotten. Many of our drugs work at the GABA-A receptor. It would be interesting if there were anti-inflammatory things that did both, and I know that they're trying to develop medicines like that, but I don't think there's anything that you need to do differently about that at this point. That isn't yet proven or available, either one. So I think for right now, it's just an interesting thing to imagine could be possible.
Okay, that's what I was wondering exactly. Thank you so much. I'll let somebody else ask a question now. I really appreciate it.
My daughter has extreme light sensitivity, and it's been a problem. And essentially, they just said that every anticonvulsive drug has that as a side effect. But this is so extreme that sometimes she can't...
Has what is light sensitivity as a side effect?
Light sensitivity, yes.
No, I don't think that's true.
That it's due to the anticonvulsant drugs?
I do not believe that all anticonvulsant drugs cause light sensitivity. No.
Oh, okay.
There are some drugs that make you more likely to get sunburns, like Tegretol. No one really understands exactly why that happens, but it sounds more to me like so light sensitivity in that she gets a headache when she's exposed to light, or light sensitivity she gets a rash or a sunburn, or what exactly do you mean by that?
Yeah, like a migraine headache.
Yeah. I don't think the medicines are causing that problem.
Okay. Okay.
There are actually some of our medicines help with light sensitivity. Topiramate and lamotrigine, many headache specialists use to help with that. So it's definitely not categorically true that all epilepsy medicines make you more light sensitive.
Okay. it's very severe. So could you suggest where we might go in another direction for what that's all about?
I think you have to talk to a headache specialist.
There's headache specialists?
Mm-hmm.
Okay.
A migraine specialist, to talk to them a little bit about what kinds of medicines might be potentially useful for that problem.
Okay, thank you very much.
Yep.
My question is if you have a kind of a mess up sleep schedule,
mm-hmm.
how do you begin to get back onto a better sleep schedule? What are the steps that you were to take to do that? And
Sure. So it's not actually that hard, and lots of people, I'm glad you asked the question because people imagine it's going to be really, really hard. I think you have to get everything out of your bedroom that looks like a television set or a bunch of books. I think you have to make sure that there's dark in your room at night, even if it means putting a tablecloth against the window. I think you try to make the temperature in your room right at night, and then you decide what time you particularly would like to go to bed. It can be 8 o'clock p.m., it can be 3 o'clock a.m., doesn't matter. You decide, when do I want to be asleep? I need to be asleep about 8 hours a day. Which 8 hours should those be? And then you try to stick to going to bed within the same half hour, even if you've gone to sleep at 4 o'clock in the morning up till now, but you'd really rather be asleep at 10. So then you say, I'm getting into bed at 10, and I'm going to get out of bed every day at 6:30 in the morning. And you keep to that. By the third day, you'll be really sleepy because you won't be able to sleep very well at 10 p.m. for the first couple of days if you're used to sleeping at 4. But by about the fifth or sixth day, you'll be able to fall asleep at 10, and by the end of a week or so, your body will expect that that's the time you're supposed to go to sleep. It'll take about a week, and you'll be tired in the middle, and if you give in to that and take a big, long 4-hour nap in the middle of the day, then you'll have to start over again.
Okay, so the other question is what if you can't get asleep? What if you have a problem going to sleep and, are you not tired out or...
So when you can't get to sleep, part of that is usually that your brain is not expecting to go to sleep then. If you can't get to sleep on that system for the first couple of days, then you just motor through the next day anyway. It's harder in people who have epilepsy because I don't want you to have a seizure either. But usually what people do to re-regulate their sleep cycle is just only allow themselves to sleep during those hours. Somewhere in the second or third day, people feel pretty sleep deprived because they're not used to sleeping those hours.
Okay. And with sleep deprivation, I was just going to ask you, you talked about, the ornery, and, the attitude and stuff like that. Could you just, give me a little bit more information on that?
You want to know what people act like when they're irritable when they're sleep deprived? Is that what you mean?
Yeah, I would really like to know, just to have it go, back and forth, because if I get,
I think most of us are different. So for some people, that means just that, if people ask too many questions at this learning chair, I'm going to snap at them. For other people, it means, boy, my mood suddenly feels really much worse, and I'm just completely unmotivated, and I don't want to do anything. For other people, it would mean, I just don't have the attention span to read this book right now or even start looking at it because I'm just too tired for that. It's often seen as moods that cycle very quickly. Irritability is a measure of that. How much you can tolerate and be patient with what other people are saying or doing or putting yourself in their shoes. Sometimes irritability is part of that. But I can't tell you for sure what it looks like for you because it depends a little on what you're...
Well, not for me. Just, in general, and it does matter.
Mm-hmm.
Okay. Well, thank you very much. I appreciate it.
One thing you mentioned was you talked about having an unusual sleep schedule. Let's say if a person goes to bed at 3 o'clock in the morning and then wakes up at noon, but they're consistent with that, is that worse than having a more natural sleep schedule?
I don't think there is a natural sleep schedule except the one that you have adopted for yourself.
Well, because you've talked about circadian rhythm and stuff like that.
Right.
And I mean, how much does that actually matter? Like, is there a time that's, you know, it's to be dark, and then, you know, like you said, like waking up at the same time every morning, or something like that, or is it like waking up every single time, you know, when you're in
does the, you know, sunset and sunrise and that kind of thing, does that actually matter once you're on a regular sleep schedule?
People who fight the sun have a harder time sleeping. People on night shifts have a harder time sleeping the shift that they want to. But you can convince your brain to sleep at the same time every day, even if the sun is out.
Then there's no problem with that then.
For most people, no.
Okay.
If you keep it pretty consistent, it's nice to have a dark room to sleep in. So if it's really bright outside, you want to do something to keep some of that bright out of the room you're sleeping.
Right. So like either whatever shift you work, you can work it as long as you have a cold room down to, and it's dark, and you've got your alarm set, and there isn't a TV and a lot of books, then then everything's okay, basically, right?
Mm-hmm.
Okay.
It can work.
Other questions? Someone else had a question?
Yeah, I had a question. This is Valores. I wanted to know, okay, when I kind of moved out my bedroom because it's two vents in there and it's hot, and so I'm in my other room, and it's cooler in there. But when sometimes I wake up in a hot sweat, and my room is cool, the other room is cool, and then sometimes I'm coughing, and I'm constantly, because I think of medicine, I'm on like 2,200 and something milligrams of medicine, and I'm finna be weaned on some more medicine. So I wake up in the middle of the night coughing, you know, just coughing on my vomit, you know. On my mucus, it's like mucus coming up. I got to drink some water, and like you say, I'm often peeing because I'm constantly drinking water for the dry mouth. And that odor is on my body. But when I get from up under my cover, it's kind of cold out, you know, in my room and stuff, so it's not hot. Do I even have a seizure? Because my body is all sweat, and then I have that odor. You know how sometimes that odor, you can kind of smell that odor?
I'm not sure if I understand perfectly the question you're asking me. Are you asking me, does the smell mean that you've had a seizure? Is that what you're asking me?
It's that smell, and I'm really hot and sweating.
Probably not.
Okay,
I don't imagine that.
And I'm choking on mucus.
I think you may have sleep apnea, actually, but I can't tell from what you're saying. It doesn't seem to me that that's likely that it's a seizure. Can I say that way?
Okay. Now, another thing, I have problems on my. I have problems sleeping with my arms, so I'm back and forth on each side of my bed. On my other bed, I'm back and forth. You know, I move a lot in my bed. With my arms, you know, I can't sleep on them, and I'm back and forth.
I'm not worried that any of those things is a seizure.
Other questions?
I have medication. I was wondering if you notice any improvement for nocturnal seizures on any particular medication.
It depends. It depends on what kind of seizure disorder the patient has. So nocturnal seizures can be a clue to us that this is frontal lobe epilepsy, which do a little bit better on some medicines than others, or it can be a clue to us. So it depends on how much that's a hint as to what kind of epilepsy the patient has. Does that make sense to you?
Yes, if it's controlling daytime seizures, awake seizures, they're still occurring at night, that's just an indicator, is what you're saying.
So if you have frontal epilepsy, which seizures tend to happen a little more at night, there are some medicines that work a little better for those than temporal lobe epilepsy. If you have a generalized epilepsy that tend to happen either as you're waking up in the morning or as you're falling asleep, there are certain medicines that are better for that.
Okay.
I'm not sure.
Okay, so just explore that with the physician.
Yeah, I think that's a hard question to answer. It depends on why you're having seizures at night as opposed to during the day. I'm sorry.
Okay. All right. Thank you.
Mm-hmm.
We've got about 2 or 3 minutes left. Any other questions? Anyone who hasn't asked a question?
Yep, I got one.
Go ahead.
My daughter has had epilepsy for 40 years, pretty much uncontrolled. She sleeps 12 hours a day, goes to bed at 10 o'clock at night, gets up at 10 o'clock in the morning almost religiously. I can wake her up and get her up probably at 8 o'clock in the morning if there's a doctor's appointment or something. But by 2 o'clock, she's sleeping. And you can't keep her awake. She, sleeps on sitting up. Is there any problem with her sleeping for 12 or 14 hours?
No, there are some patients with epilepsy who need to sleep more than other people. I have seen that happen before.
Okay, no problem with that.
No, I think if that's what she needs and she feels well the rest of the time, then she should do that.
Okay, thank you.
Mm-hmm.
One question that kind of was mentioned a little bit earlier, but napping. Do you have an opinion on napping and whether naps are a good thing, and if so, how long you should nap and when?
So I don't believe that naps should replace the amount of sleep you need to have at night. Mm-hmm. I think that doesn't work out very well. But I think that if people need extra sleep during the day, especially after taking some of their medicines that make them sleepy, there's nothing bad about napping.
Okay.
So I have some patients who know that they will have their seizures usually when they wake up, and they prefer not to nap because then that just puts more potential risk times of day in front of them. But for most people, it's not a bad thing.
Is there a length of nap? If you nap for too long, does that have the potential to disrupt your nighttime sleep?
More than an hour and a half, usually.
Okay, great.
Russ knows the answers to all of these questions that he's asking already.
I have a crazy question. This is
I don't believe that.
You said that to me at the support group one night.
There are no crazy questions.
I have to take pain medicine for my neck injury yet, because when it pops, there's times I feel like I'm going to black out. So he's got me on pain medicine. I'm on medication due to depression with my husband, and I'm on sleeping pills.
Okay.
If I take them at 6 p.m. and then at 8, I can sleep from 10 at night till noon.
Okay.
So how can I work that around so I can I haven't been feeling like wanting to do anything since July.
I think you probably need to be on less medicine altogether would be my guess.
Then I can't sleep.
Well,
that's my big problem. I live alone.
It sounds like you're sleeping 12 hours or 14 hours now from what you're telling me, from 10 p.m. till noon.
Yeah.
So there must be something in between sleeping 12 hours and sleeping not at all.
Mm-hmm.
I would think very seriously about which medicines really help you function better and do better things, and which medicines don't. And I think you have to think about sleep as not something that is best when it's initiated by medicines.
Right. It was Monday. I didn't sleep at all, and I took all that. I was up all night.
I understand. I think some of those medicines, I don't know what you're all taking again, but benzodiazepines and other things make your sleep worse.
Okay.
So I'm not sure what to tell you about that, but that's a little scary to me.
I just came back from a long trip, so maybe that might have a little problem in there too.
Mm-hmm.
Okay.
Okay, well, it is 7:30, so we're going to have to wrap it up. But Dr. Selwa, I really want to thank you for your time. It was fascinating as always.